Okay, so now see the session is the difficult situation in the SICS or in the cataract surgery. And when you think of the SICS, there is no any difficult situation in SICS, but of course there is a difficult situation in the cataract surgery. So how to handle it, I will talk to you.
Thank you so
Now
much.
see, these are the problems where you can thoda light dim karo. Uh, okay. Now see, the difficult situations definitely are there. You can see the subluxation, non-dilating pupil. You can see the calcified cataract. You can see the pseudo-exfoliation. You can see the corneal opacities. You can see the anteriorly dislocated or the intumescent cataract. So all these situations where the phaco is not possible, we try to do it with the SICS, and for the SICS, yes, we can manage such situations by SICS. So all these things you have seen just now, and then you can see the small pupil. This can be functional or fixed, or it is a pseudo exfoliation, difficult rhexis, PC tear, or the IOL implantation, or zonular weaknesses. These are the cases where you get the causes of small pupil and what can the complications in that. Now, how you can manage in this situation? You can use the strong mydriatics, 10% the phenylephrine and cyclopentolate, or you can use the viscomydriasis or iris hook, or you can use the pupil expanders, sphincterotomy and CTR in few cases. Now the managing strategy, see all parameters lower than the normal and liberal use of visco. Now SICS in the small pupil, you will just see the small pupil, and here the nucleus is larger than the pupil. So whenever you are doing the small pupil, here you see the tunnel is made in the scleral place. See, always remember, upar aa jao. These are the back cuts because the lens has also got the thickness. And see this,
Very good.
the tunnel, the pockets are made so that internal opening will be 7 millimeter and external opening will be 5.5 millimeter. Because see, unless and until the cataract what you are removing, see here what I am doing is I am doing the rhexis. This is a case where I was not using the dye, but now I use the dye, but you will see the rhexis is done behind the pupil. So rhexis is not done just inside the pupil, but behind the iris rhexis is done. And this is the larger rhexis that is done for the SICS. In the small rhexis, and when the pupil is small, the lens will not come out. Otherwise, total bag will come out. See now here the lens has come out. Now again you will have to bring the lens outside the pupil. So deliveries from two places. One is the rhexis and second is the pupil. So whenever there is a small pupil, you will have to deliver the lens from two places. This is the Blumenthal technique, and I use the glide to remove the nucleus, and you can see the epinucleus is also removed. So once that epinucleus and this is removed, then it is possible to go ahead, clear the cortex, and always remember that you will have to also repose the capsule. Now here what happens, the nucleus is large, the less molding and the endothelial damage may happen because it is a hard nucleus. So this hard nucleus can damage the endothelium. Now here important thing is the pockets. It means internal opening is very very important whenever you are dealing with the hard cataract or the nuclear cataract. Then the tunnel should be larger. So don't worry for the tunnel. If the tunnel is larger, the nucleus will come out properly, and rhexis should be larger. If this rhexis is not larger, the nucleus will come with the capsule, not within the capsule, with the capsule, so that there will be aphakia. Now see, this is the brown cataract, and once you are removing this, you can see the tunnel. Can you see this is in the white area, and once it is in the white area, I am extending this extension on the both sides. See here. So, and then what you should see here is, what is important is the tunnel, pockets. See here. The pocket I am going straight to the here, and then on the other side you will see the pockets. So what is, and now again I am doing the rhexis. So once the rhexis is now here, also I have not used the dye. So without dye also you can do the rhexis if you can do it. Otherwise better to use the dye. See here, while going in you cut. You can see the internally minimum 1 millimeter of the cornea you must cut. If that is not cut, then this tunnel will not work properly. And now see the, after that I have just, the nucleus is inside the outside the rhexis, and whenever you are bringing the nucleus out, partial nucleus should be out, and then don't make noise, please. Are please, people, audio visual people. So see here now the lens is implanted in the bag and that finishes the hard cataract. Now in the black cataract, now see this is the black cataract. See here, again always remember the incision size here, you have seen in the previous case, this size is larger than the previous size. See here. So I am just enlarging it by going inside the pockets, and whenever I am extending, I extend in the same plane. Plane is very important. Otherwise in between there may be two planes and the nucleus may not come out. See here, while going in you cut. See here. And then once you have made it properly and inside opening is 7 millimeter, then only you can see the nucleus. See here, the nucleus is, engagement of the nucleus in this situation is very important. Now how engagement you can see when you see the tip, that nucleus is engaged. So this is a very hard nucleus. If you do it by phaco, it will take near about 20 minutes. But this is removed in 20 seconds. So whenever you are dealing with any such type of hard cataract, or you can say the nuclear cataract, always it is better to go with this. And now I am just by the, this is AC maintainer and I am doing it by this. Now the other is white cataract, where it is the rhexis. The visibility is poor, dense nucleus, there is no glow seen. So how you can manage? Same, dye assisted and large rhexis you can do, and internal tunnel. In this such all situations, now this is the hypermatured cataract where I am doing the Bulmenthal. You can see this. So after doing the cautery, you can see, always remember here extension of the tunnel on both the sides. Now opening is here, it is a 5.5 millimeter only, as it is not a nuclear but it is a cortical cataract, and you see I am going in the same plane. Once I go in the same plane, then I go to the pockets. And once go to the pockets, see here, the in the pockets you will see the extension is made, and then now again you will see, while I am going in, can you see this? Here, as you see, the entry is very, very important. See here, the dimple is there, you can see the dimple, and once you see minimum 1 millimeter of the cornea, otherwise iris will come out, and this is an hypermature cataract. See how I am doing it. Can you see this? The envelope technique. It is not required that you should go for the rhexis only, but in such situations, sometimes rhexis is not possible. You can do by the envelope technique, and see here, the nucleus comes automatically in the anterior chamber, and once it comes in the anterior chamber, see here, I am bringing it out. Now in such types, I will advise use some Visco. Hydro expression in this situation, it is in new hand, it is not possible, so I have removed the nucleus, and you can see the capsule. You can see the anterior capsule, and what I am doing is just implanting the lens behind the capsule. Now once I have implanted, then I will cut the capsule, and once that capsule is cut, then by the forceps, you see, by the forceps, the rhexis can be done. So properly rhexis can be done, and by the envelope technique you can complete the this one. The conclusion is SIC is easy to learn, easy to this practice and skilled procedure to master. First surgery to 1 lakh surgery technique remains the same. Another thing is, in such, there is no difficult situation if you keep your technique correct. It is wonderful weapon in your hand to treat complications of cataract surgery. So whenever there is any complication, you can treat that complication by this weapon. So SICS, I always feel, is the best weapon for the cataract surgeon. Don't feel that you are doing SICS and you are an inferior surgeon. No. For the cataract surgery, now I will ask Dr. Ragini Parekh, who is a professor and head in the Grant Medical College, and she will talk on the 10 steps of the SICS. Dr. Ragini Parekh. Yes, it is done by peribulbar anesthesia. Also you can do with the conjunctival injection, but in that you should be conscious, and you must also give the you can say intraocular. Now phenocaine is there, use intraocular phenocaine, subconjunctival injection superiorly, wait for 2 minutes, and once you wait for 2 minutes, then you cut and do the tunnel, and once you do the tunnel, then from side port you must inject the phenocaine, wait for 1 minute, and after that you go inside. Otherwise, here it is not like phaco. The lens is going to touch the iris, and once the iris is touched, patient will experience the pain. And to avoid that, peribulbar is better. But if you want to avoid the peribulbar, yes, it is possible. You can just give the superior or temporal injection of the xylocaine 2%, and then intracameral injection of the phenocaine, and you can do it. Okay, Dr. Ragini is a professor and head in the Grant Medical College. She has done the 85,000 cataract surgeries, which is highest in any lady in the world. So she is going to speak to you about the 10 tips of perfection to perform SICS. Dr. Ragini.
Thank you, sir. Respected, respected Padma Shri Dr. Lani sir, my teacher who taught me surgery, Dr. Santosh Bude, who is the Vice President of the Maharashtra Ophthalmic Society and a close friend, respected teachers and friends. I don't have any financial interest. So, people, we do perform phacoemulsification. At Sir JJ Hospital, I'm 100% phaco surgeon if the patient can afford to pay for a foldable lens. But when we go to the rural area, there are patients with very hard cataracts with pseudo exfoliation. So it is very important to have SICS as a part of the inventory or the repertoire of your cataract surgery techniques, because it is okay not to know phacoemulsification when you start surgery, but it is very important to know SICS. Dr. Blumenthal sir did come to JJ, and sir went to Israel where he learned how to do Blumenthal surgery. Everybody is a beginner before they can become an expert. We all know the basic steps of cataract surgery, and every single step, even from positioning the patient, because if the patient is with the head low, there will be vitreous pressure. Using a proper speculum, because there are so many times that a small speculum with a small palpebral fissure which cause pressure on the vitreous. So no step is small in cataract surgery, and your minor mistake or error, even in choosing a speculum, can cause vitreous loss or an expulsive hemorrhage. The bridle suture is extremely important in Visco Expression techniques, because you need to pull the suture. So every step is important. The conjunctival flap is very, very important, because when you reposit the conjunctival flap, it keeps the wound safe. And also the next day, all phaco patients with a corneal tunnel are very, very comfortable. And I used to find that Sir's SICS patients are comfortable, but mine are not. So I started wondering what Sir was doing. And I found that Sir's conjunctival flap was so perfect that it used to cover like a hood, and the wound was not exposed, and that is why the patients, if you do not see the superior wound, were looking like phacoemulsification. So every single step is important. Sclerocorneal tunnel. I have seen lots of people advocating premium lenses or corneal tunnels, cutting the nucleus. The nucleus is very big, and you have to remove it through as small an incision as possible. But a corneal incision which is more than 3.2 millimeters is not safe with respect to astigmatism and with respect to infection. More infection than astigmatism. So if you want to do a smaller incision, we must do phacoemulsification. So there is no other way around that you say that I only know SICS. We can drive cars like Lahane sir told me. So we have learned cataract surgery, so we can learn phacoemulsification too. So SICS, essentially the tunnel is a sclerocorneal tunnel. Capsulorhexis, it can be done even with capsulotomy. That is the beauty of SICS. It can be done with a can opener. Phacoemulsification cannot be done without a capsulorhexis. Anterior chamber entry, hydro procedures, nuclear rotation. The nucleus has to be separated from the bag in SICS, because you want to bring it first out of the bag into the anterior chamber and from there outside. So this is a separate step than ECC. The delivery of the nucleus, cortex aspiration. This is a small incision cataract surgery. So cortex aspiration here will be different than in extracapsular surgery. One must remember that. IOL implantation, and if you see, the last step is written as reposition of the flap, which I was talking about, which is a very, very important thing. So this is the conjunctival flap. So making the conjunctival flap is extremely important, and if you see, you do not make it at 12 o'clock, you make it a little apart, like say not exactly at 12 o'clock, but 1 o'clock, 1.5 o'clock. So this helps the flap to get reposited back, like when you are completing the incision. So that is very, very important. So as you can see, and using the correct instrumentation, using the cornea forceps and and you can see this at the end, you reposited it back and the incision was taken here. And because it is slightly larger and not at 12 o'clock, this sits like a hood. If it is at 12 o'clock, with the movement of the lid, it gets retracted. So even a small basic step, just by changing the site of your conjunctival flap from here to here, will make a difference in surgery. Just small changes. So this is exactly what I have been saying for the last 1 minute or two. Then the incision. Every incision we divided into parts. Okay, so the size or the length of the tunnel, the width, the depth, the location, entry into the anterior chamber, and the shape. So the length of the tunnel, the width of the tunnel, the depth of the tunnel means how deep it is into the sclera, the shape of the tunnel is all very, very important to make a successful SICS surgery and to give you good results. We are here talking about how to better our SICS surgery and make it perfect. So that's very, very important. So if you see, these are the different types of incisions. Okay, so this incision where it is parallel to the limbus will cause a lot of astigmatism, and that is not to be done. This is very easy to make. This is what we teach our residents, because what we teach them is make a straight line 1.5 millimeters behind the limbus and then make back cuts. So while teaching them, we teach them कि एक boat बनाओ जैसे स्कूल में बनाते थे, so एक उल्टा boat बनाइए. This is a modified frown, which is correct. So this is not very good, and these straight lines are not very good because you don't have availability of a scleral pocket. So each incision has two parts, the external incision, which is a groove on the sclera, this one, and the internal incision. So that they both work into as harmony for an entry port and to make a valve effect. It is very, very important that the corneal tunnel, so this is the initial groove up to half depth of the sclera. You make it with a blade. After that, you dissect the tunnel into the sclera and also into the stroma of the cornea. So this is the second plane, and this is the entry, which is the third plane. It is only because it is a triplanar incision that it will seal properly and it will create a wall effect. So that is the self-sealing wall. Now, like I already said, is that it is a sclerocorneal tunnel and it is a funnel. In the sense, this is the external incision, this is the internal incision. But these scleral pockets, which Sir was saying, is the place where a large nucleus will be able to come out through the incision, and also at the same time, the external incision, which is the incision which is responsible for the astigmatism, will continue to remain small. So it is very important to make a funnel. So as you can see over here, I'm a left-handed surgeon. This is a mature cataract, a straight line and back cuts, which is the initial first part of the incision, that is the groove on the sclera. We use proper blades. These are very, very reasonably rated now in India. Indian blades are very good. One set costs you about 175 rupees and use and throw. So this, as you can see, this is the pocket. This is the scleral pocket. This is the scleral pocket. And this is the external. Now this is the entry and extension of the incision. So you cut when you go in. So the external, as you can see, is here, and the internal, as you can see, is there, which allows the nucleus to mold. So which is very, very important. So one more, that was a mature cataract. This is Sir's video, which is a right-handed surgeon, as you can see. So the conjunctival flap, which I said is extremely important. And cautery. So not too much of cautery, but not too little cautery is extremely important. If too much of cautery is used, then the sclera will be affected and it will affect your healing. So incision 1.5 millimeters behind the limbus and a modified frown incision. Now dissection in the mid sclera, and here there is no cutting. It is just separation of the collagenous layers of the sclera. And also that part of the sclera continues into the cornea. So that's very, very important. And the entry, as you can see over here, this is the entry. Cutting as you go in, which is extremely important. And making the incision. So this is the incision. some more videos about the incision, because what is different in phaco and SICS is the incision itself. So that is extremely necessary to do this properly. So the incision, as you can see very clearly over here, it's a modified frown incision. It's a modified video, large, so that it can be seen very clearly. And the dissection with a crescent blade, where the tunnel is dissected by making pockets, as you can see, which is very, very important. So dissection of the pockets, making the tunnel, there's a lot of patience and you can take a lot of time, because if the tunnel is not properly constructed, if there is premature entry, the whole surgery is spoiled. These are the side ports. Using the correct MVR bait for the side port is also important. And this was the Blumenthal port, the AC maintainer port entry. So using the correct instrumentation is very important. And now this is the entry inside the eye and the extension, as we can see over here. So the making of the tunnel is extremely important, right? This is the practical tip 2. So after that, this is a fully dilated pupil and a good glow. I am left-handed, so you can see the rexes being made, but it can be made with a needle, it can be made with a Utratas forceps, and the beauty of SICS is that it can be done without a rexis. Of course, there is no two ways to making a good rexis, and a good rexis gives you IOL implantation inside the bag. So this is a small pupil. As you can see, a rexis can still be made, and you can make the rexis, as you can see, even in a small pupil. Now the tip here of making a rexis in a small pupil is that to remain within the pupil itself. Because if we try to go behind the iris, what may happen is that you may not see and the rexis will run away. So this is making of the rexis. So using a good viscoelastic, a properly dilated pupil, a deep anterior chamber, and using a cystostome if there are problems, hydrodissection is very, very important. Not hydrodissection, but hydro procedures. Hydrodissection is not done in posterior polar cataracts. Using multiple points of hydro fluid will keep it safe. There is no danger of PC tear. And you see the golden ring, slight elevation of the nucleus, then rotating the nucleus to make it free is the end point of hydrodissection. So you have to be very, very careful. Nucleus delivery techniques, there are lots of techniques. As you can see, lots of techniques are enumerated here. Visco expression, Blumenthal, phacominnification. As many surgeons as are sitting here, there can be that many techniques. You can use one technique and the other technique, modify it, make it into your own special technique and use it. Visco expression is using viscoelastic to deliver the nucleus, as you can see over here. So if you can see over here, this is the tunnel being made. I think we have seen a lot of tunnels. So this is the rexis. This is the hydrodissection, where you will be able to see and using viscoelastic now to protect the corneal endothelium. You use a needle and to impale the nucleus, move it down at 6 o'clock slightly. You can see the pole. Using a carousal technique, bring it into the anterior chamber, pull the superior rectus. Only after the nucleus is engaged, inject viscoelastic and the nucleus comes out. So that's extremely important, and this is the aspiration of cortex using the AC maintainer. So that is extremely important. In Blumenthal's technique, we will be seeing here. So this is the hydrodissection. You can see the use of AC maintainer. In Blumenthal's technique, a glide is used. So once the nucleus is separated with hydrodissection, the nucleus is lifted, rotated and brought into the anterior chamber. This is extremely important, a free nucleus and bringing the nucleus into the anterior chamber. and using a glide. Now this glide is very, very cheap. It is available, we buy it from Madhu Instruments, it's not, and now it's available with every seller. And then glide means, the name suggests it helps the nucleus to glide out of the eye, and the AC maintainer is there. So these are the two techniques. Glide, you have to place it properly so that otherwise there will be a PC tear. And you have to use viscoelastic always, which is extremely important. So as you can see over here, again, Visco Expression where the nucleus is delivered. Even very, very hard nuclei can be delivered out of the eye. And if the nucleus, and you can see now, if you just press on the sclera, the epinucleus also can be delivered. Now, if part of the nucleus remains, it can be turned. The AC maintainer is used and it can still be removed. So, various techniques, as you can see, can be combined. My second talk is small so that I can explain this. So, as you can see, part of the nucleus remained. You can turn it and this part can be expressed. So, various techniques can be combined together for the nucleus delivery. Cortex aspiration is different. Bimanual techniques, as you can see over here. This is the anterior chamber maintainer, and this is what they call the Lahane's cannula, single port aspiration cannula, which he modified from the Blumenthal cannula. The advantage of this is that you can use 3 ports, the main port and the side port, for 360-degree cortex removal, and a complete cortical cleanup is possible. And using the AC maintainer keeps the bag inflated, keeps the posterior capsule behind, so that there is very less chances of PC tear. You can, because we are doing SICS because you are using a rigid lens. If there was a foldable lens, then it would be phacoemulsification. So as you can see over here, this can be done in the viscoelastic, or as you can see with the AC maintainer and the ringer lactate, so that the chamber is already formed. Dialing the lens inside the bag is very, very easy, but it can be done even with viscoelastic. Hydrating the ports at the end of the surgery is extremely important. Leaving a tight wound is extremely important. And IOL, removing the viscoelastic at the end of the surgery and repositing the conjunctival flap. So what is important is to observe, practice and learn. Correct technique protecting the eye structures is important. To select easy cases, and our main aim is to convert to phacoemulsification. This is a very practical class that we have to do SICS. So that's why. We have to learn phacoemulsification too. I welcome our senior teacher, Dr. Kamaljeet Singh sir. We have parallel courses where I'll be talking in his class and he is talking here. So, and also Dr. Parikshit Gokte sir, who is the member of the scientific committee and who is the LOC member of this beautiful conference that you are seeing. So, if it is okay, then I'll ask Dr. Kamaljeet Singh sir to please give his talk so that he can then go back and continue his course. If somebody can help with this AV, because I think, sir, you will be presenting from your computer.
Yes.
Yes, sir. And if there will be time, I think, but if there are any time or in between till everything, if anybody has any questions, we can take them.
I think
till
he sets up the computer, maybe if anybody has question, he can ask.
Yes, that's what. So
and Professor Kamaljeet Singh is going to talk on modifications.
No, sir. Conjunctival flap, we cut at the limbus. So it is a fornix based flap.
If we take some part of the conjunctiva behind the limbus, it can cover the wound.
No. So it is easier to reposit it, and you. Yes, that's true. That's true.
We can cover the wound.
Yes, sir. So that's a good tip, sir. You may need sometimes.
Ma'am, what's the maximum size of the wound that we can make in SICS?
So the thing is that, see, you start with 4 millimeters also. I've done SICS with 4.5 in very, very soft young cataracts. And in black cataracts, you can make a larger incision. But you need not go to 7-8 millimeters, because then it does not serve the purpose and it will cause a lot of astigmatism. So it can be done with a 6 millimeter incision in a case of a very, very Niagara cataract, but your pockets have to be very deep. And in case you find that your incision is big, we always advocate that we say it is suture-less surgery, but let us make it as a less suture surgery, because we are taking lesser sutures. But in case where you have a doubt, where there is a buttonhole, where there is a premature entry, it is always safe. It is better to put one suture rather than have problems with a wound or with infection. So in case you are using a larger incision, then it is better to put in a suture. Temporal incisions, see, in case you have a filtering bleb and all that, regularly we are not doing temporal incisions. It is better to do superior incisions because it is safe because they are covered by the lid. But sometimes in a patient with a bleb, we would rather do a clear corneal phacoemulsification. But at a camp and all that, we have done temporal incisions, covering it well, but you have to be very careful because they are then exposed in the palpable area. Please, sir.
If you have taken a temporal incision, I will prefer to suture it. So don't bother whether it is sutureless or with suture. You should suture. Yes, that's why you should suture it.
We have not seen any infection even with temporal incisions, but the problem there is not because of your incision. It is you have ended up doing a temporal incision because there was a problem, because there was a bleb superiorly. Otherwise, you wouldn't do temporal. So there, anyway, the conjunctiva, there is a problem. So you would like to.
Thank you, ma'am. Yes, two things I learned from this discussion was that whether you can do a 4 millimeter incision cataract surgery or not. This question was raised, and I'll be showing that only. And temporal incision is made, number one, as Madam has told, that when there is a bleb there, then you go to the temporal side, or if there is a steep meridian when you are doing keratometry, if you do a steeper meridian, that means 43 and 46, if it is on the horizontal side, then you make a temporal incision. Greater the astigmatism, more nearer you are to the limbus, so that will correct that much of astigmatism. So that can be done easily without any problem. Temporal incisions people are making, and these days I have done studies on corneal topography, and I have found that it's usually the steepness is slightly oblique. On the right side, for that this right eye, there would be superotemporal steepness is more, and in the left eye it's superonasal. So you can make a superotemporal for the right eye or superonasal for the, in most of the cases you would be correcting the astigmatism. You can take the advantage of surgically induced astigmatism that is there with the small incision cataract surgery. So you can make it astigmatic when you like to do. This is my
Thank you, sir. So Dr. Kamaljit Singh, sir, is a very, very senior professor, one of the advocates of SICS surgery. Even like I was saying earlier that, everybody is a very, very prolific phacosurgeon. But to teach SICS, and the most practical thing is that so much is being talked in phaco, and we are phacosurgeons in an institute. But the statistics in India show that around 70 to 80% of the cataracts are still by SICS. He has conducted courses all over. He's conducted very, very large volume surgeries in phacoemulsification and in SICS.
Yes, ma'am, I think it's videos. So this is a video of 4 millimeter incision, a hypermature cataract, that too phacomorphic. So I tried this doing in 4 millimeter incision. You can see I am close to the limbus, and I am trying to do rhexis. In this case, in a hypermature cataract, you all know that there could be a Argentina flag sign. And here, since the cataract is large, you have to make a large capsular rhexis, and forceps comes into play here. And you see it has extended little there, but gradually you inject Visilone, and then you can pull it towards the center, and your rhexis would be round, continuous but not round. So it's large capsular axis, it's there, and what you do is that you aspirate the cortical matter from both the sides, the side port and the main incision, so that the nucleus size becomes smaller. So this can be done, and then you extend the incision slightly inside, slightly more, maybe 4.5 to 5 millimeter, and then rotate it. It will come out of the bag easily, and you can see it is so much swollen. And you inject fluid, and then with the what you do is that you take the vectis down, and with the Sinski dialer or a chopper, if it's not very hard, although phacomorphic glaucoma was there in this patient, but what you do is that you keep your vectis here like this, and top of that you can keep a chopper and just hold it firmly and just dip it down, and from downwards you bring the lens towards your chopper or dialer. It will break into two without any problem. You have to inject lots of visco in this case, and you will be successful in this case. So I have done just one maneuver of this kind, and you can see there are 3 pieces, and we can then remove this with visco. You make it slightly vertically this thing, and then you can take it out, and you can aspirate this visco expression of the epinucleus, and from the side port or the main port you wash it, and you implant a foldable IOL. So this is a very easy technique, provided you are comfortable with your vectis and chopper. Don't push it too hard, just keep it firm there so that you don't hit with the chopper, you hit into the posterior capsule. And many a times I do phaco also in this way. 2.8 millimeter incision, pop the nucleus out of the bag, and with 2 choppers, slightly like Professor Keki Mehta says that this is a salute sign. So what I do is that I take the chopper from one side, from the other side I crush it. It breaks into 2 like you do in a high vacuum phacoemulsification. Then you simply take out the nucleus without any problem, and the surgery is excellent. The phaco energy is also almost not there. So that can be done. You see, this is another case with the rexus there. This is not that hard. You dial it and you will find that it can be propped up. And you can make it into like you do it trenching in the phacoemulsification with the dialer or a chopper. And if it is not very hard, you can separate it very easily with visco. You can see it can be done. Keep on injecting visco so that the chamber remains deep, and then you further do it. It's almost like chopping through phacoemulsification. The phaco tip here is much smaller than the phaco tip you really have. This is a manual phaco tip that is there, and then you rotate it a little bit. Bring it into anterior chamber, and this was the technique I was discussing, flag salute sign, and you just chop it like this. If the visco is there, there is no problem in the cornea. Cornea remains absolutely clear the next day, and these smaller pieces can then be taken out through a smaller incision. Just visco express them. And then bimanual irrigation aspiration can be done. The chamber remains watertight, and the lens can be implanted through under the fluid. So these are two techniques that I wanted to share with you all. Thank you.
Thank you, Dr. Kamalji Singh sir. Kamalji Singh sir is a professor in the Regional Institute in the Allahabad, and he is my best friend since beginning. When I started my career of ophthalmology, we became a friend, and since that time we are like brothers. And his course is going on in Hall P, and my course is going here. So we are exchanging the speakers because always we are the same speakers. And though the Parikshit is a guy from the scientific committee, he has given us a small hall. Uh, though he is one of the speaker, not himself, but he has not concentrated properly. So thank you very much, sir.
Thank you, sir.
And I will now invite the Santosh, who is going to speak to us on the SIS with the premium IOL. Santosh. Sir, you can take the speaker with you. Thank you. So, so till he is a Santosh, open ho gaya? The SICS, I think those who are doing SICS, they should be happy because SICS is the surgery, and you should not feel inferior. I always feel superior that I can do SICS. So,
Okay.
Santosh.
Respected chairpersons on the dais, senior colleagues and friends, good afternoon. I'm going to talk in this SICS session of update to upgrade. So if you are a SICS surgeon, you should upgrade and start using premium IOLs. If you don't want to update to phaco, I won't say upgrade because both surgeries are equivalent, both surgeries are good. So when I say upgrade, you may feel that phaco is better, but it is nothing like that. Both are good. But if you want to update your skills, then you should start using premium IOLs. Our wish as a cataract surgeon is always to give 6x6 and N6 vision to all the patients and clear cornea on day one. And I'm sure that we can achieve clear cornea on day one in all cases of SICS. Though I am a 95% phaco surgeon, I won't say that I will give 100% clear cornea on day one. So I'm going to talk on SICS with premium IOL. I do not have any financial interest in any of the products mentioned in this talk. When you talk about premium IOL and implantation of a premium IOL, which essentially means either a multifocal IOL or a toric IOL or toric multifocal IOL. So it is not only a science, but it's an art, and it goes beyond evaluation of the eyes of the patient. It takes into account personality of the patient and specific requirements of the patient depending on his or her occupation. It also involves in challenging explaining intricacies of premium IOL technology, because if you say that I'm going to put multifocal IOL, patients' expectations will reach sky high. And if those expectations are not met with, then patient will be an unhappy patient. Though patient may get 6x6 and N6 vision unaided, but patient satisfaction will not be there. After considering all these pre-operative things, then comes the most important thing of performing a surgery, which is a next challenge. And if you are doing SICS and if you want to implant premium IOL, it is really challenging. See, whenever we attend conferences and whenever we see prolific surgeons showing you some gymnastics, it is not in day-to-day life that they are also doing in every case that way. And they have reached that level after doing so many surgeries. So your take-home message is not that from next day onwards you just start copying that surgeon and start performing the same way. You have to evolve your own technique. You should, there is something like SWOT analysis. You should know your strengths, weaknesses, and other things. So first thing is that points which we should consider before putting premium IOLs are, what is the need for premium IOL for that patient? You have to talk to the patient, you have to give chair time. Enough chair time should be given. If you talk to the patient, then patient will not be unhappy. You will realize his expectations and you will tell him the realistic outcome. And then you have to decide choice of premium IOL, whether multifocal should be used or extended depth multifocal should be used, or trifocal or toric multifocal has to be used. Another thing is pre-operative examination of the patient. If you are thinking of putting premium IOL, it is most important. Look for dry eyes, because you may do perfect surgery, but if patient has dry eye, then patient will be unhappy patient. Watch and examine pre-operative astigmatism thoroughly. You should know your surgically induced astigmatism. You should be perfect. It should be repeatable. When I do phaco, I know that I will induce so much of astigmatism when I perform surgery. Same thing, you should be confident that you will be inducing so much of astigmatism in particular axis. But unfortunately, in SICS surgery, there are multiple factors which decide surgically induced astigmatism. In phaco, there are very less factors. But in SICS, there are the wound construction, the tunnel construction, the depth of tunnel. There are so many things. So every time the surgically induced astigmatism may not be same. Surgically induced astigmatism also depends on location of incision and whether you are using the astigmatic neutral funnel. Then comes most important, removal of nucleus from that small incision, whether like Professor Kamaljeet has shown 4 mm incision. So a grade 4, 5, 6 cataract you cannot remove. Everybody cannot remove through that. So if patient with that grade asks for premium IOL, you should tell him realistic outcome and you should not tell him something which is not going to be achieved. Patient selection is most important. Just avoid demanding, hyperactive, critical, type A personality. Just avoid that patient. Patient with irregular astigmatism, avoid. Previous history of refractive surgery, penetrating keratoplasties, avoid such patients. Zonular dehiscence, don't do premium IOLs. Those who are driving at night, those who are in profession who want to drive at night, avoid those patients. And those patients who have strong desire for spectacle independence, give them realistic outcome and their expectation, try to understand their expectation. A thorough routine clinical examination. Important point in this is the accurate biometry is of utmost importance. You may do perfect surgery, you may remove hardest of the nucleus through smallest of the incision, but if your biometry is wrong, then everything goes haywire. Surgical technique. In surgical technique, क्या हो रहा है यार? स्लाइड पुढे का नहीं जाते? नेक्स्ट करते हैं ना स्लाइड. हाँ, ओके. Capsulorhexis is important if you are planning a premium IOL. A perfect capsulorhexis is a must. See, when we perform SICS, we have an advantage. Even if you are not able to perform proper capsulorhexis, still you will be able to do perfect surgery. But if you want to implant a premium IOL, effective lens position is one thing which is of most importance. And to achieve that effective lens position, your capsulorhexis has to be perfect. It should be of adequate size. Lahane sir has already explained that if it is very small, accidentally you may remove entire lens instead of removing only nucleus. Proper centration of capsulorhexis is most important. Sorry. Tunnel construction, the next step, it is also very important. The tip for proper tunnel construction is that your blade initially should be perpendicular to the sclera. The depth has to be 50% of the scleral thickness. And the incision should be either frown shaped, chevron shaped, or inverted bat wing. Inverted batwing means you have seen so many videos of sir as well as Ragini madam. All those incisions are inverted batwing incisions. And it should be in astigmatically neutral funnel. Then you will induce less astigmatism and you will be consistent in your surgical induced astigmatism. So as I said, that surgical induced astigmatism is most important. It is multifactorial in manual SICS as compared to phacosurgery, and surgeon should be confident and consistent in achieving the same good results. Now comes the nucleus delivery or nucleus management. Now hard nucleus, large nucleus, removing through a small tunnel is really challenging. So there are certain minification techniques which are used. This is snare technique, and we are proud that a surgeon from our own Maharashtra, from Nandurbar, Dr. Anil Shah, has developed this technique almost 30 years ago. He uses steel wire to make a snare, and he cuts hardest of the nucleus into smallest of the pieces, and he removes all those smallest pieces through the smallest of the incision. But everybody cannot achieve that. You have to achieve that level. Another thing is my loop. It's a Nitinol loop. It is actually, I will say, similar to the technique of Dr. Shah, Anil Shah. And Nitinol is an element which is made of nickel and titanium of 300 microns, and it has good elasticity, good memory, and a good cutting power. Advantage is that it goes through 1.5 millimeter and expands to almost 10.5 millimeters. And it can be used inside the back for cutting the nucleus. Another technique developed by Dr. Sudhir Singh from Mount Abu is nucleus fracture, intratunnel fracture technique. That is also good. So ultimately, as a surgeon, you have to develop your own technique to minimize the nucleus and remove hardest of the nucleus through the smallest of the tunnel. Another good way of managing astigmatism is customized incision cataract surgery. This surgery is popularized by Dr. Boramani from Mumbai. And most of the prolific SICS surgeons perform this. They take incision on the steep axis, and since they know that surgically induced astigmatism is X, so that they can neutralize that particular astigmatism if we take that incision on the steep axis. There is another technique which is a software-based technique developed by Dr. Raut. He is a surgeon from Pune, but I do not have personal experience of it. And that is also good, that's what he claims. One should have a strong intraoperative exclusion criteria. Even if you have promised a surgeon of doing a premium IOL, you should be bold enough to exclude case if you face an extension of capsulorhexis to periphery, if there is too much of eccentric capsulorhexis, if there is accidental damage to zonules, if there is trauma to pupil during surgery, and if there is vitreous loss. To summarize, proper understanding of needs of the patient and selection of premium IOL technology is a must. Preoperative counseling and sufficient chair time should be given by the operating surgeon. Surgically induced astigmatism of the surgeon has to be properly analyzed before venturing into premium IOLs in manual SICS or even in phaco. To choose premium IOL wisely according to the need, the current refractive error, and demands of the patient. Every patient may not be a suitable candidate for premium IOL due to his condition and demands and limitation of current technology, so you have to explain it to the patient. So always under-promise and over-perform. I thank you, and I thank again for giving me opportunity to share my thoughts. Thank you.
Thank you, Santosh. I think Santosh has whatever he has shown you that yes, premium IOL is possible in the SICS. First I will request the Parikshit, is the member scientific committee, and you might be not knowing. He was selected for the IPS, and he has not joined IPS, and he has joined the ophthalmology, and he is now the member of scientific committee of India. He is going to speak to us on various techniques of the SICS, Dr. Parikshit. Huh?
Yes. Night driving. Yes. No, no, you don't avoid the patient, you do the surgery, but avoid putting premium IOL. I never said avoid the patient.
No, we are not there to avoid the patient.
Don't
We are
put
there
premium
to
IOL.
avoid the things which will trouble the patient. And if patient is a driving person and if you put an premium, no, multifocal. You should not go for multifocal.
You
Other
can,
lenses you can
premium
do.
means
Yes,
I'm
Parikshit.
talking about multifocal lenses
You can go
because
for
he can
the,
have glare and
You
halos.
can
while
go for
driving.
toric and all others, but here
Yes.
you will not. And even now extended depth, yes, you can go for that. Yes, Parikshit.
Thank you, Lahane sir. I would request all the persons in the last row, there are seats in the front. So in case somebody else wants to come, they can come and sit. You can please, you're welcome to sit in the front. Well, thanks to sir and ma'am, we run this course for the last almost 10 years and always there are enthusiastic takers. It's heartening to see manual SICS halls are always full and there is so much that manual SICS can do. Today I have been given a brief to speak about the various techniques of small incision cataract surgery. I'll be just running you through the 10 techniques that are the most common ones that are possible. But before I do that, this is just a small video of the technique that we most commonly do, that is Visco Expression. This is a technique that was first started, popularized in Arvind Eye Hospital. You make the tunnel, you put in lot of Visco and you just press on the floor of the tunnel and the nucleus just glides out. So it looks very simple and well, it is in many ways simple. But as everybody who has done both phaco and SICS knows that in many ways SICS needs more skill to do than phacoemulsification. But there are various places where manual SICS is as good or perhaps even superior to phacoemulsification. Hard cataracts, brown cataracts, many kinds of subluxated lenses, places where corneas are not very good, that is very old patients or patients with Fuchs endothelial dystrophy, the SICS is much, much better. So in the SICS, there are actually two places only where we have to have more skill. Even in phaco or in any cataract surgery, we need a good tunnel, we need a good CCC. That is now a norm, a prerequisite that all of us have to do. Here, prolapsing the nucleus into the anterior chamber is the key step in almost all SICS technique, and that is why having a well-dilated pupil is very, very important. So using NSAID eye drops before surgery, seeing to it that a proper dilating thing is put before surgery is very important. I mean, if we have not promised the patient, even peribulbar blocks work well, subtenon blocks work well. People do SICS under topical anesthesia, parabulbar anesthesia, but for long-term safety and especially where high volume surgery is done, peribulbar block or subtenon anesthesia is very important. Also, small pupils make nucleus delivery difficult and increase the chances of manipulation of iris and cause iritis. So we should avoid that. We should take steps preemptively to see that the pupils are not small. These are the 9 most common types of SICS that are done. Of course, everybody has his or her own variant, but the irrigating vectis, the blue menthal, phaco fracture, phaco sandwich, phaco trisection, the fish hook technique, the snare, the intratunnel fracture, the smart SICS, nowadays the 3 millimeter SICS, and the list keeps on growing. This is the one, the irrigating vectis or Visco Expression, in which we have a slightly larger incision and the vectis keeps on giving out water, and when you press on the lip, there is more pressure inside, less pressure outside, and the nucleus glides out. This is the video we just saw. It's a fast procedure. there has to be a well-formed anterior chamber throughout the procedure, and the brunt of the nucleus is borne by the walls of the tunnel, and this is safe for the corneal endothelium. In the blue menthol techniques, the lovely videos that Professor Ragini ma'am had shown, there it is the AC maintainer that is maintaining the anterior chamber, which is keeping the nucleus away from the endothelium. Here it is the irrigating fluid and also the viscoelastic. So in many ways, it is like getting the paste out of the toothpaste like we do every morning. We open up the nozzle and we press. Now, if we press gently, the toothpaste or even eye ointment will come out gently. If it is done in a haste, then too much of ointment can come. So if we try to do this too fast, the nucleus can come out too fast. There can be a decompression inside, and it can lead to a PC rent as the vitreous comes up. So the internal hydrostatic pressure has to be maintained. The nucleus is stretching on the walls of the tunnel, and here of course we are giving pressure on the posterior lip, and by giving pressure on the lip, we are opening the mouth. So the more controlled this is done, the safer this is for the patient and for us in the long run. These are now only of historical significance. This is phaco sandwich. Well, we are all very proud that India is the home of manual small incision surgery, or rather the Indian subcontinent, Nepal, Bangladesh, Pakistan. But some of these techniques were first tried in the United States in the 1980s, before phaco became popular. And here the nucleus is squeezed between the lens loop and the iris spatula. Now, because it's a large nucleus and we are putting in two instruments, we need a larger tunnel. But some of the nucleus that we see in the Indian setting are very, very hard nuclei. So to get that into the anterior chamber and to put two instruments, one below and one above, sometimes can be difficult. The same problem is there with the phaco fracture technique, which was introduced by Dr. Peter Kansas again in late 1980s, where there was a bisector or a trisector, which would divide the nucleus into two pieces. So the bisector would chop it into two. A trisector will make it into three. The trisector was easier because the resultant pieces are now three pieces, and we can remove them by McPherson one by one. But again, if it is a very big nucleus, the trisector on top, the platform below can make it very difficult. Compared to that, in the blue menthol technique or the visco expulsion technique, we just put pressure on the lip. We do not put any instruments inside. So this is the blue menthol technique, the lovely videos that ma'am showed. There is the sheets glide and the AC maintainer, which has less than 1 millimeter diameter. This keeps the AC formed all the time, and you don't need a lot of viscoelastic. So all the problems with remaining visco, so secondary glaucoma, perhaps later uveitis, all of them are avoided in the blue menthol technique. And because the AC is formed all the time, chances of iritis, chances of endothelial damage are also very less. In fact, it is this technique that made SICS more common. Sure, okay, we'll do this later. Again, all of them can be used for black cataracts, for brown cataracts, for hard brown cataracts. And again, we all emphasize too much on the small in small incision cataract surgery. But then some of the nuclei that we see are really very big. In phacoemulsification, the nucleus is broken down into literally micro particles and just aspirated. Here we are removing the nucleus in toto. So in case you see a very black cataract, it makes a sense to have a slightly bigger tunnel, the inner lip much bigger than the outer lip, to have very good scleral pockets, because once the nucleus comes out, it will need space for it to come out. And also for the nucleus to get into the anterior chamber, the rhexis also will have to be much larger. A lot of us surgeons today are used to doing phacoemulsification, so we tend to make the rhexis smaller so as to have good lens centration. But in cataracts like this, perhaps slightly bigger rhexis are needed. And the nucleus delivery and all the various ways we saw is the most traumatic step for the patient and the surgeon, especially when we are learning SICS or when we are converting from phaco to SICS for whatever reason. So the tunnel has to be adequate and proper. See that the nucleus is bathed in visco, and nowadays we have excellent viscoelastics. And we have done randomized control trials trying to compare HPMC, that's hydroxypropyl methyl cellulose, which costs 50 or 60 rupees, with sodium hyaluronate, which costs 400, 800 rupees. And well, there is hardly any difference. But whatever visco we have, we should use it in plenty. This is not the time to be miserly. And the delivery should be gradual and controlled and not sudden decompression, as it can lead to a PC rent. And finally, in all the techniques, one thing always to be looked at is the corneal endothelium. These cells are not replaceable, so we minimize endothelial touch or endothelial injury either by the instruments, by nucleus, or by IOLs. Make the maneuvers away from the cornea. And again, as surgeons, we focus too much on astigmatism. We think astigmatism is something that is very wrong, you know. That's why we do phaco and smaller incisions and toric IOLs. But in SICS, there is a trade-off between lesser astigmatism, that is smaller incision size, and corneal clarity, endothelial cell loss. We may make a very small tunnel and we may get the nucleus out, and we are very happy that the astigmatism is less. But 2 years, 3 years down the line, if we do the specular microscopy of these patients, their endothelial cell counts have fallen down. So it's not worth it. In fact, again, meta-analysis have shown that small amount of astigmatism in SICS gives near vision, because it's like the Stroom's conoid. The smart SICS techniques works on that, because the horizontal and the vertical corneal curvatures are slightly different. So that increases the depth of focus. So the EDOF lenses that we put, and we pay a lot of money to put in those lenses, something like that automatically happens in SICS. So when you, I'm sure all of you must have seen phaco patients. In phaco patients, we are happy patient reads 6/6. Patient is not that happy because he says, I could read my mobile, I could read my newspaper without specs earlier, and now I cannot see anything for near. But if you will see your SICS patients, they may not read 6/6, they may read 6/9 or 6/12, but they are able to read or see their mobile. And nowadays, everybody has the mobile because of this effect, because of the small residual astigmatism that is there. And one last one is, of course, in SICS, if the tunnel is large or not that good, we many a times get a shallow anterior chamber, and that can be seen on the first dressing. So many people think that the suture is bad. Well, yeah, it's not the most ideal thing to do in a cataract surgery, but then wound gape or iris prolapse increase chances of endophthalmitis, astigmatism. So whenever needed, we should suture it. And finally, SICS gives best functional vision, unaided 6/12 for distance, unaided N8 or N10 for near, and it gives the best intermediate vision, which is what nowadays people want to do by putting in very expensive lenses. So it's a great surgery, and I'm sure all of us should keep on doing it.
Thank you,
Thank you.
Parikshit. Parikshit is the scientist, and now I will call upon Dr. Ragini, and she will speak to us on the surface diseases in the eye, where how we can go for the SICS. Dr. Ragini.
Thank you, sir. Thank you, sir.
I think Parikshit has given very good overview about the different techniques and
One more
any
talk is there from sir, but I will finish my talk fast because I took some more time in the previous talk.
Yes, surface. Okay.
What if we operate this patient? If you see this patient has a small pupil, there is a pterygium, there is a chronic conjunctival redness as you can see, and there is mebomonitis, which is very, very clear when you can see the enlarged section. So as you can see, there is mebum in this patient, and if we miss this, because if you're not examining the patient on the slit lamp, the patient has foreign body sensation, pain and watering. The patient is 6 by 6 but not 6 by 6. So, you don't have a happy patient. You feel that the patient is reading 6 by 6, but the patient is not comfortable, so unhappy patient and stressed doctors. I must take this opportunity to thank Sumit for making our lovely presentations. So, there are lots of clinical trials, and the definition of dry eyes has changed over a period of years. Now there are large textbooks on tears, because you used to just say that there is a tear film, you add just tears. But now you know that there are different layers of the tear film which are responsible, and each layer may contribute to the dry eye. So pre-operatively, if you have a misdiagnosed dry eye, then what does it happen? And you are going to give the patient, and there will be increased surgical time, incision size, lens hardness, more inflammation and reduction in the globulate cell. And what happens is that post-operatively you are using drops. So many of the patients who have mild dry eyes, who have no complaints, but we are giving 5 weeks of post-operative steroid drops. The patient says that they are not comfortable. They call you up and they say that they have redness. You are scared that it is inflammation of iritis, but it is actually a dry eye, which may be missed when you are not looking for the dry eye. So as you can see over here, that the patient has come with circumciliary congestion, and only after the stain you can make out the tear breakup time and this irregular tear film, which is the cause of the dry eyes. So what is it that you would like to do pre-operatively? So it is not only important that you assess the patient for a cataract. Many a times we are so cataract oriented that we see the patient, we see the cataract, and we decide to operate the patient. But a corneal surgeon would be more careful, and I think we have to pay attention to the cornea, because like Lahani sir taught me, that you treat the cornea like God, because it is irreplaceable. So this is a patient with a corneal opacity and a cataract. If you can see, this is a metaherpetic lesion, and this is what the patient comes with. So what went wrong? So as you can see over here, this is a patient and this is what happened. So what went wrong was that no non-steroidal anti-inflammatory drugs. I know a friend of mine who is no more from Mumbai, who had a corneal melt with a particular drop post-operative to cataract surgery, and his surgery was very good, and the patient lost vision, and both the surgeon and the patient were upset. So in a patient of dry eyes, you have to be very, very careful. Wait for this condition to be better. Treat it maybe for a longer duration if the cataract is immature. Examine the corneal sensations, which we normally would not do. So it's extremely important. As you can see, this is a mimosa plant, and this is the ocular surface. It's extremely delicate. Systemic disease, preoperative factors, postoperative surgical factors all affect the ocular surface. And we are not talking only of the tear film, we talk of the ocular surface as a whole. So the patient may have pre-existing systemic disease. A patient may walk in not even telling you that they have rheumatoid arthritis or Sjogren's. The incision, the size of the incision, additional surgery, time of surgery, irrigation, and the pre-operative factors, like I already said, are all very, very important. So many factors have to be taken into consideration when you are doing it. So array of drops, self-medication. We have some patients who do not put the drops, and some people who by putting more drops, they will get better results. So the disease which was pre-existing and which was missed may get aggravated. Of course, the systemic factors, the ACs, the humidity, the dryness, ocular allergy to the preservatives, contact lens, so many factors affect the ocular surface. So it's very, very important. So you have to be very careful. You have so many artificial tears. Vernal keratoconjunctivitis, you are seeing nowadays patients with posterior subcapsular cataract, and all these factors are anti that the patient had a vernal keratoconjunctivitis. So you have to be very careful that you perform only in a non-inflamed eye. These are special conditions where you have to be very, very careful before operating the patient. So you have to manage the dry eye, reconstruction or rehabilitation of the ocular surface, replacement, whatever treatment is possible, and now corneal specialists are available, perform better to avoid corneal incisions. So the conclusion is that one must keep in mind the presence of a dry eye, a mild dry eye, or something that is overt, which may get aggravated post-operatively because of the surgery, because of the drugs, and then we may land into trouble. So while doing slit lamp examination is to examine the eye properly for the ocular surface disease, and then only proceed for any surgery, especially SICS or phaco, for good results, because otherwise there will be a unhappy patient who may even lose the eye. Thank you so much. Thank you so much, sir. Thank you, sir, for being my teacher and teaching us. And thank you, friends. There's one last talk. There is no other session, and we got the session slightly late. It's very important to listen to sir, that how is it possible that we can give our patients 6x6 vision. Thank you so much.
No, see, not for all post-operative cases. See, pre-operative or post-operative. Always remember, the tear film problems are there in the cases, you will have to diagnose that. On the slit lamp, you see meibomian glands. If the glands are affected more than 10, you feel that patient is having the MGD. So treat the patient, give hot fomentation, give antibiotics, ask them to press like this, and after the, you can say 1 month, you can operate. If patient is having the dry eye, yes, of course in the dry eye, you can give the artificial tears, not only tears, also the gel, and that will help. It means whenever you are operating such type of cases, in these cases, always better to treat it before surgery. Because after surgery, the surface is irregular, and again that will cause the problem. And if not, then you will have to see conjunctiva properly. If you are cutting the conjunctiva, repose it properly. Otherwise, do cauterization of the conjunctiva, and surface should be regular. And then you can also give the artificial tears with the the unaided 6x6. Is it possible with SICS? Yes, it is possible with SICS. Only thing is that we always feel SICS is inferior surgery, and because of that, we are not taking care of the surgery. When there is a phaco, then we will see that these so many things, and topo, then copo, everything. And then when there is SICS, SICS to hai na, kar dalo. It means you always feel ki are SICS kar rahe means nothing. See, if you take it seriously, SICS, you can give better result than phaco. Not only 6x6, but 6x6 and also N6, or not N6 but N10. Patient will be able to see the watch, and the patient will be able to see the newspapers and mobile, when without extended depth lens. So SICS itself is the extended depth focus lens. So if you are doing EDAF, so forget going phaco and do SICS, it is EDAF. So it is like that. So always remember, see what happens, we ourselves are discriminating. Are kyun karna hai? Why you are doing such type of cases? No. You can give 6x6, but your mindset is not 6x6. So you make your mindset 6x6, you will give it. Your mindset in SICS is 6x5, as in phaco. But what you are doing? You are never giving 6x5. You are giving 6x9, 6x6 partial, like that. But mindset is 6x4. Yes, you can see the chant when you put this phacoemulsification. So it is like that. Now here the benchmark, standard of the refractive outcomes after the cataract surgery, you can see this is what is the benchmark, and this is a paper presentation, and in that you can see more than 90% of the patient post-operatively, it is plus or minus 1 diopter, more than 90%. So this you will have to avoid. How? Now refraction is -1 diopter. What went wrong? Why can't I see last line clearly, doctor? So what went wrong? So I will tell you what went wrong is what I am missing. So I am missing is the measurement error, because ये कोई कर दिया है, yes, go ahead. IOL calculation, here the IOL is calculated for the just sake of calculation. IOL position alignment, nothing is seen. IOL is just implanted and forget, because that is SICS. Type of IOL, whatever is high level, you put IOL, you put any, means the foldable, non-foldable, any type of IOL in the back, and then you see, yes, I have done it. That is what is the mindset of SICS. I always say, this is the mindset of doctor. And the corneal pathology, if there is a corneal pathology, phaco is avoided and SICS is done, and you feel the patient should read 6/6 and N6. And the retinal pathology, the phaco is avoided and SICS is done. It means all blame games are done with SICS, and I am very unhappy for that. So don't blame the SICS, blame the mindset, and do all these things. If you do all these things properly, you will give results better than phaco. Now see the estimation of the post-operative IOL position, determination of the post-operative refraction, and measurement of axial length. Nobody who is doing SICS is not taking care of his astigmatism. Okay, but if you are doing phaco, then say, my factor, my that factor, my this factor. But why there should be a factor in this only phaco? Why not? That is a, see, in Marathi, phaco is phekundya. You go for SICS, and when you are going for SICS, the mindset should be proper. And that is, if it is done, then you must know what is your astigmatism, how much it is going in the 180 degree, 90 degree, 120 degree, but nothing is seen. And then the after that you can measure it properly. Then to avoid measurement errors, the non-contact optical biometer you can use. IOL master also you can use, or you can use the immersion technique. It's always better to use the immersion technique, that will give a good result. And the posterior subcapsular cataract is there, or mature cataract is there, because here IOL master doesn't work properly. Then the repeated measurement. See what happens? Repeated measurement, are we doing repeated measurement? No. Because SICS, na? One measurement, one lens, this one, go ahead. So this is what happens. So repeated measurement, so that you can have one, this one IOL calculation formula. You can use the Holiday, Hopper, SRKT, Huggies, or Holiday 2. Are we using these formulas? No. We are using whatever the formula is there on the Apaswami machine, whatever it comes out, that is the SICS. And once it is not there in other formulas, then we go for all formulating. We'll call the friends, we'll go to the, you can say Google, then we'll see which formula, I am not getting proper this one. Then they will call the refractive surgeon, अरे भाई इसका LASIK किया है, what is the lens calculation? And if you are doing SICS, okay, SICS, okay. They push any IOL. The SICS is any IOL. And when you are, there is a phaco, you can say course, 10 people. SICS course, 200 people. Still their their mentality is, अरे कर दो, no formula. So please apply the formula, though is SICS. It's a cataract surgery. And then you will be more happy. So repeat, this is, then we will go for the, you can see this, the axial length, how to use the formula. More than 21.5. Minimum इसका एक photograph ले लो, 21.5 Hopper. Then 21.2 to 26 Holiday 1. And more than 26 SRKT. Okay. Use only these 3 formulas for SICS. Only 3 formula. And next year if you will come to my course, you will know, अरे बाप रे मेरा result बहुत अच्छा है. Nothing more than that. Only formula. 3 formula and everything is all right. Then the other thing is IOL position and alignment. Now see, size of the capsular axis has a direct relation to the effective lens position. Effective lens position is there only and only in the premium lenses, and that is only in the phaco. Why? Effective lens position is for every lens, That may be a free lens, or that may be a, you can say, rigid lens, or that may be a hydrophobic, hydrophilic, any lens. Effective lens position is very important. But for us, mindset says premium. Premium, then the ELP is seen. Why? Second day patient is going to ask you, मुझे vision नहीं है. Why other we are not taking care? He is not going to ask you, अरे दिख रहा है. Finger counting 5 meter, patient is happy. 6 by 6, patient is unhappy. And you are taking care for that 6 by 6. And you are not taking care for this finger counting. Please take care of that. Second thing is the femto cataract, japtocapsulotomy, intraocular lenses, intraoperative overlay, so many things are there. And then capsulotomy is, you can say it should be the 5.5 or more or slightly larger, because you are removing the lens out. Then the anterior capsule fibrosis or the fibrotic shift is there when it is less than 5.5. Increased rates of the tilt of the lens or decentration. So it should be proper the size of this. Then the intraocular lenses, trifocal, accommodative, multifocal, toric. Can you use this? Yes. Why not? See, it is, lenses are not incision dependent. Lenses are required for the different type of vision in that patient. It is not related to your incision. Incision may be 5.5, but you can put accommodative lenses on possible. In small incision, it is not possible to implant accommodative lens. But in large incision, it is possible to implant accommodative lens. Also the multifocal lenses, yes, you can do it, no problem. Results are good, only you will have to think of your astigmatism. If you are properly taking care, yes, you can use any type of lenses. It is not for the small incision surgery. See, the aims of both are different. Lens is for the vision and surgery is for the type of surgery. It means if you are doing phaco, probe should pass. If you are doing SICS, lens should come out. So different aims are there, but the lens you can implant any lens anywhere. What is required there is rhexis. Rhexis is important, incision is not important, always remember. So if you are putting multifocal in SICS, you are not an inferior surgeon. You are a surgeon where you have thought of the patient, also thought of your skill, also thought of the lens, and you have removed the cataract. So that is what required. Now this is the corneal pathology. You can see so many types of pathologies. इसके बाद है क्या? हाँ, हो जाओ, बैठ जाओ. Okay, इसके बाद बेल नहीं बजना चाहिए, बंद करो. क्या है? We pay them. After that also वही आपने को भुन-भुन करते रहे. बंद करो. नहीं तो अभी से मैं तुम्हारे न्यूमरेटर निकाल दूंगा.
Sir, Parikshit bhai say he has listened to your earlier instructions कि इतना बेल बजाने को.
Okay.
He is following your
So corneal pathology. Yes, there is a corneal pathology. Is anybody operating phaco? Then they say कि नहीं, उसको illumination अंदर से करो, बाहर से illumination करो, inside illumination करो, then retro illumination करो, but do the phaco. अरे बाबा क्यों करता है? Do SICS, no illumination is required, but patient's vision is illuminated. That you are not understanding. If you do the phaco, nothing is illuminated. जो भी endothelium था तुम खा चुके हो, तो patient को कहाँ दिखने वाला है? He is not going to see at all. But still you are phaco. What is, I don't understand. So corneal pathology, you can go for the SICS and patient will see whatever he was unable to see before cataract. If you do the phacoemulsification, his vision is reduced by 30% after phacoemulsification in the corneal opacity. You see any research anywhere. The other is the retinal pathology. See, if such type pathology is there, the phaco surgeon says, refer to the other surgeon. He never operates. जैसे आपको थोड़ा सा रेटिना में प्रॉब्लम लग रहा है, तो ये बहुत अच्छे सर्जन हैं, उनके पास जाइए. He is SICS सर्जन, उधर जाओ. So if this is there, you also tell कि भाई SICS surgeon is there, but we can't centralize the lens. he is the best surgeon, he can do. I always refer such patient to a phaco surgeon who always say कि फेंको, जाओ, उसके पास करो फेंको जाके. Then patient will come back, अरे भाई कुछ नहीं दिखता है. मैं बोलता है वो फेंको सर्जन है. तो हमारे पास तो हम तो स्मॉल सर्जन हैं, क्योंकि हम स्मॉल इंसिजन करते हैं. वो फेंको वाले हैं वो तो, और फेंको वाला हर सर्जन इज इन द कोर्ट. मैं तो शर्ट डालता है, मतलब कि उसके पास जाए.
कल सीएम सर
In the incision, see, the incision is very important. So here you can see the first is the astigmatism, and accordingly take the incision. Why you are taking incision accordingly in phaco? Why not in SICS? SICS can correct more astigmatism than phaco incision,
What is decided?
because their LIR is required. Here it is not required. You are going for 5.5. So this incision will correct 1 or 1.5 millimeter of astigmatism, which is not corrected in the phacoemulsification. So your mindset should be checked. Yes, हमको करना है. Go for the such type of different type of incisions. Then the pre-operative counseling. Now what is pre-operative counseling? Patient आ गया, Ragini and Santosh. Patient आ गया. Cataract, I will operate tomorrow. Fundus is not seen. Nothing is seen. There may be anything behind. Cataract is seen, grade 1, or you can say some changes in the lens, cataract. Then आपको बाद में cataract नहीं होगा. You will not get the cataract. Secondly, I will put a multifocal. नजदीक का दिखेगा, दूर का दिखेगा. And he will not develop the cataract. It means patient coming after 40 years of age to the doctor is a crime. उसका लेंस निकाल के मल्टीफोकल डाला एक आंख में, अदर आई में नहीं गया है. Then patient is handicapped throughout the life. So what happens? So what we are doing? Only over promises. What is over promises? You can read everything. You can do anything. 6 by 5, 6 by 4, 6 by 3. But it comes to 3 by 6. Then there is a problem. So don't over promise. Tell कि भाई इसमें सर्जरी है तो विजन आ सकता है, बट कितना आएगा बोल नहीं सकते. अच्छा विजन जरूर आएगा. तो उसके बाद वो पेशेंट तुम्हारे पास नहीं आएगा. आई ऑलवेज से माई पीपल, व्हेन द पर्सन कम्स टू यू, आस्क यू थ्री क्वेश्चंस फॉर द प्रीमियम लेंस. आस्क द पेशेंट कि भाई गांव में ये डॉक्टर बहुत अच्छे हैं, जो तुम्हारे बहुत अच्छे दोस्त है, इनटू ब्रैकेट एनिमी, उसके पास भेज दो. जो क्वेश्चन पूछने वाला है 3 क्वेश्चन, उसके 30 क्वेश्चन हो जाते हैं बाद में. और कभी कभी तो वो एक ऐसा लंबा लिस्ट लेके आता है क्वेश्चन का. मैं बोलता है कि ये पेशेंट को ऑपरेट नहीं करना है. आई ओनली आंसर 2 क्वेश्चंस. व्हेन 3rd क्वेश्चन इज आस्क, आई टेल ओके माय रेसिडेंट को मिलो. एंड व्हेन इन लेसिक आल्सो, व्हेन पेशेंट इज कमिंग एंड आस्किंग 3 क्वेश्चंस, मैं बोलता हूँ मेरे रेसिडेंट को मिलो. रेसिडेंट इज स्टार्ट कि पेशेंट उनके पास आया है तो उसका ऑपरेशन नहीं करना है, उसको कहीं जाना है, जाने 2-4 बार जो भी आना है. सो ऑलवेज रिमेंबर, क्वेश्चन पूछने वाला आदमी क्या क्या करता है. द पर्सन हु इज आस्किंग यू द क्वेश्चंस, पेशेंट तुम्हारा एक क्वेश्चन में तुम्हारा 1 महीने का लाइफ कम करता है. ही इज गोइंग टू आस्क यू रिपीटेड क्वेश्चंस. एंड व्हाट इज हैपनिंग? योर हार्ट वेसल्स आर कॉन्ट्रैक्टेड. Every time you are answering, there is a contraction of the vessel after fuses, angioplasty, angiography, everything. Why? He is asking question. कितना पैसा देने वाला? 10,000. Why you are worrying for that? दूसरा आएगा. Such type of people should not be answered so many questions. उसके आंसर नहीं देना है, जाओ जाओ करना है जहाँ करो. But always remember, our health is more important than patient eye. Always remember. And if our health is important, then why we should go for such type of things?
पहली बार लाइफ में
हाँ?
आपने ऐसा बोला और हमने आज पहली बार ऐसा सीखा.
और इंसिजन में तो आपको मैंने बोला है कि क्या क्या कहाँ कहाँ करना चाहिए. दैट आई विल शो. अरे क्या हुआ? हाँ, डोंट प्रॉमिस स्काई. वी प्रॉमिस स्काई एंड देन गिव रियलिटी चेक ऑलवेज. देन समरी, accurate eye measurement. I think you might have in the brain, everything is now inside कि भाई 3 फार्मूले यूज़ करना है, इसमें से जो भी है वो उसको यूज़ करना है. विदाउट फार्मूला करना नहीं है. इमर्शन यूज़ करना है. एक्यूरेट आई मेजरमेंट करते हो, डू इट एक्यूरेट आई मेजरमेंट. देन द करेक्ट IOL selection. So don't select rigid IOL in SICS. Don't select rigid IOL in SICS. That is our rigid mindset. Please fold your mindset in foldable lenses. You can use foldable lenses. They are not incision dependent. Always remember. So fold. Then the updating IOL constant. Your IOL constant, you will have to update for SICS also first time, because you have not updated up till now. Okay, do it. Then the retinal evaluation. It is, you are doing only phaco, do it in SICS also please. And the topography, yes, required. And the patient counseling also required. And if there is a difficult phaco, that is if you are having the black cataract, do SICS, put IOL, and if patient is operated somewhere for the phaco on other eye, he has came to you, don't do phaco, do SICS. He will be very happy, because first experience he is having, he was unable to see for 8-10 days. If you will see on second day, yes surgeon bahut acha hai, what you have done, SICS. So that gives you the patient will be happy. And I think perfection is not attainable, but if we chase this perfection, we can catch excellence in SICS also. Thank you very much. Best wishes.
Yes, we have concluded the session. Thank you so much.
Yes, yes.
You can ask any question.
Sir has taught them and he has taken special classes for all.
Okay.
And now he is worried.
If you have got any question, we will answer. If not question, next time we will answer. No problem.
I wanted to ask one question. Sir, if I have a patient with very hard cataract and has a pre-existing cylinder of maybe more than 3 at 90, pre-existing cylinder, and he cannot afford a toric lens, and I am not confident with temporal SICS, so what should I do?
SICS on the temporal and SICS on superior is same. Only the mindset.
Sang na.
मुझे temporal नहीं आता है. I will tell you, temporal SICS is easiest than the superior. Why? Superior there is a hurdle. Your the heartbeat. There is no. So in such situation, don't do any other thing. Go for the temporal SICS. Go for the temporal SICS, and you will be happy. And do SICS like superior only. Think that it is a superior portion. Just change your mind of direction, do it temporally, you will be successful.
Sir, can I do a superior and put a infinity suture?
No.
Yeah, that's what.
That you can do, but why you are doing suture and all other headaches? I will tell you, go for temporal. Temporal better now, why in phaco only you should sit temporally? By my opinion, you can sit temporally in SICS also. Yes, sutures can definitely help, but not for 3 diopter. Not for 3 diopter. If it is 1 diopter, suture will help. But for 3 diopter, temporal will help.
Thank you, sir. Thank you. Thank you, friends, for a lovely
Thank you very much.
session and for the
Thank you.
encouragement.
Thank you very
Thank
much.
you, Dr. Gopte, sir, Dr. Santosh Bide, sir, Dr. Kamaljeet Singh, sir, and thank you.
Thank
friends.
you, Parikshit.
Sir, you
Thank you,
made it
Santosh, and
all
thank you,
the
everybody.
fun. And thank you, everybody, all the AV guys and the hall coordinators. Thank you. Yes, sir, photo.